Welcome to Nursing 498, where I'm going to look at the treatment of some of the chronic health conditions, and this week it's on the musculoskeletal disorders. So the goals of these recordings and this class is to discuss the nursing management of fractures, of osteoarthritis, osteoporosis, congenital musculoskeletal dysfunctions, and then we'll talk about caring for the immobilized patient. So when we're looking at a patient with fractures, we need to look at overall goals. So our knocks for that are going to include anatomical realignment of the bone fragments. And anytime that a bone is manipulated to get it back into alignment, it's called a reduction. There can be an open reduction or a closed reduction. Open means that they've opened the skin to get right at the bone to help it get it back into line, or a closed reduction is manipulating it without an incision. So another goal is to immobilize to maintain realignment and restoration of normal or near normal function. So a patient with an open fracture, of course, we have to remember that the bone has been exposed to the environment, so they're at risk of an infection. So we have to have some goals around preventing an infection in the soft tissue or in the bone itself. So nursing interventions could include irrigation and debridement, sterile dressing changes, antibiotic administration. Anytime that there's an open wound, we need to take a look at the patient's tetanus prophylaxis. When was the last time they had a tetanus shot? And we also have to watch our wound for signs of complications. We want another goal to be promote healing, and our nursing interventions around that would be nutrition optimization, ongoing wound care, drain management if there's any discharge from the wound at all, and we have to encourage mobilization to reduce the risks of immobility. So patients with a closed fracture, our nursing goals or our knocks would be to help the patient in self-management of the swelling and the pain. So generally, if it's a closed fracture, it's been reduced. If it's a closed reduction, the patient isn't admitted to hospital, but in the cast clinic, if we're working there, we need to make sure that the patient can care for themselves when they go home. And that would include to watch for complications such as compartment syndrome when they have a cast on. So we'd also need to do patient teaching around pain control, rest, ice, and elevation, and to maintain patients' activity to allow for immobilization to promote healing. So neurovascular function, we would need to have nursing interventions around watching for the CSM, the peripheral vascular assessment, pedal pulses, capillary refill, edema. We'd monitor temperature, motor function, would be elevating the limb. We would be reducing swelling with ice, and we'd be making sure that we're monitoring the skin. So collaborative care for a closed reduction, and like I said, the manual realignment of bone fragments is the reduction, and closed means that they didn't have to go into the bone to manipulate it. Sometimes traction is used, and that is to restore position, length, and alignment. So a closed reduction is generally done under either local or general anesthetic, and then casting is applied. There can be an external fixation. So here you'll see that the fixator that holds the bone pieces in place is on the outside of the hand or outside of the limb. And if someone was to have an external fixator, we would also have to watch for symptoms of infection around the pin sites. An internal fixator includes rods and screws and bolts and those types of things that are applied directly to the bone through an incision. And again, that is to allow for stabilization, to allow for healing. Traction may be used until a patient is physiologically stable enough to withstand an open reduction, and that's in the case of someone with a fractured hip, say an elderly patient not nutritionally sound or healthy enough to have their hip surgically repaired, and so a traction could be applied as a temporary to maintain that immobility until the patient is stable enough to go to the operating room to have a open reduction and internal fixation. So traction is a pulling force with a counter traction, and it's more often used in kids to avoid injury to the growth plate. So it also prevents pain, reduces muscle spasm, it immobilizes a joint, it reduces the fracture or the dislocation. It can be used to treat pathological joint conditions such as cancer. It can promote active and passive exercises, and traction can be used to expand a joint space during arthroscopy, during joint reconstruction surgery, so to allow more space in that joint to get an arthroscope in. So there's two types of traction. There's a skin traction, and it's generally used for just short term, so 48 to 72 hours, and it's used, tapes and boots and splints are applied to the skin to assist in the reduction until the patient is stable enough for surgery, like I had said. And skeletal traction is where wires or pins are inserted into the bone surgically, and we have to remember that if it's done surgically and there's pins, there can be a risk for infection. The skeletal traction is to help align injured bones. It's to treat bone contractures or congenital hip dysplasia in the case of kids. And it can be used, the use of excessive weight in traction could cause a delayed union. So we have to make sure that we're using enough traction to keep the bone in a line, but not too much traction to delay the healing of the bone. And Buck's traction here is one that's used most commonly for a hip fracture. So surgical repair of fractured hips is, there's two types, and it can be an internal fixation, and the one here in A is where the whole head has been replaced, and that's called a femoral head endoprosthesis, and that's used where there's been an intercapsulary fracture, so a fracture anywhere on the neck of the femur into that acetabulum would often be treated with an endoprosthetic, and that's going to allow for early mobilization. And intercapsulary fractions are usually replaces that whole head of the femur, like I said. Extracapsulary fractures are repaired with sliding hip screws, and you can see that's a picture here in B. And intermedullary devices and replacement prostheses. So depending on where the fracture is in the hip as to what type of repair is done for the hip, the nursing care for both of these are the same. So pre and post-operative care, I am going to spend more time working on this in class. I have an activity that I'm going to want you guys to do to look at how we treat a patient and take care of them so that they can recover from a hip replacement surgery or a fractured hip surgery. But one thing we do need to be aware of is how healthy is the patient preoperatively? Do they have other comorbidities that's going to impact their healing? So is there diabetes, or is there other mobility problems that's going to put them at risk for deep vein thrombosis or pulmonary embolisms? So we'll return to the hip fracture surgery in class when we get together on Tuesday. One thing we do need to keep in mind is assessing the injured limb the CSM, the circulation, sensation, and motion. So whether they have a cast on or an injury or a splint, you know this from looking after patients on a medical surgical unit, that we have to monitor their CSM. So circulation, is it warm to touch? Are both limbs equal in size? Is the peripheral pulses present? Is there adequate capillary refill? So the sensation piece is, does the client feel pain? Is the pain within the normal limits, or is there a possible problem with compartment syndrome? Can the patient distinguish between different sensations? So is it a touch or is it a painful stimulation when you're touching their foot? Is the client aware of the position of the limb? And motion, of course, we want to assess, can the patient move their extremities? Can the patient do this independently? And can the client do this on command? And I talked a little bit in 497 about the 6 P's to assessment of a fracture. I just wanted to cover that again because it's something that we should be doing when we're looking after a patient that's had a fracture or a cast or immobilized by one reason or another with a bone injury. So the 6 P's, pain and point of tenderness. Pulse is distal to the fracture site. Is there pallor? So what's the color of the fractured site? Is there paresthesia? So the sensation to the digit of the fractured site. Paralysis, is there movement distal to the fracture site, and pressure? We always want to keep in mind that there's a risk of compartment syndrome. So we need to understand there's a risk to pressure inside that compartment. And always with our bones, we need to think health promotion, disease and injury prevention. The Alberta Health Services Hip Care Pathways Toolkit I've included in your readings because we'll be using that tool to help us care for our patients with fractures. And we do have a responsibility to help prevent falls, and there is fall prevention programs through Alberta Health Services and public education. HealthLink Alberta and My Health Alberta also has resources available for patients. And then prevention also includes monitoring our patients' nutrition, so their calcium and their vitamin D supplementation is something that maybe we should be advocating for in our long-term care facilities to help maintain both bone health in our patients.